Let's dive straight into the Step 2 CK glomerular disease diagnostic funnel. We're skipping the fluff and focusing purely on high-yield clinical logic and next best step decision-making. Our diagnostic roadmap covers nephrotic versus nephritic patterns, classic nephrotic and nephritic pathologies, rapidly progressive GN, systemic diseases, and the exact next step diagnostic algorithm. Section 1. Nephrotic versus nephritic patterns, the core divide. Nephrotic syndrome essentially means podocyte injury. You're going to see heavy proteinuria, hypoalbuminemia, edema, hyperlipidemia, and lipiduria with those classic oval fat bodies. On the flip side, nephritic syndrome means the glomerular basement membrane is ruptured with severe inflammation. That presents with hematuria, RBC casts, hypertension, edema, and variable renal dysfunction. They can overlap, so you'll use age, triggers, complement levels, and biopsy patterns to differentiate. Notice how increased glomerular permeability leads directly to hypoproteinemia. That loss of oncotic pressure triggers edema and hypovolemia, which then spikes the RAS system to cause even more fluid retention. Meanwhile, the liver tries to compensate for the lost protein, directly causing hyperlipidemia. Section 2. Classic nephrotic syndrome pathologies. The proteinuria branch. Let's look at minimal change disease. This is super common in children. The classic presentation is a kid with abrupt edema right after a URI, an allergy, or an immunization. Light microscopy is completely normal, but electron microscopy gives it away with foot processed effacement. The next best step is giving steroids, and the response is usually excellent. Next is focal segmental glomerulosclerosis, or FSGS, which causes nephrotic syndrome in adults. You've got to link this to HIV, obesity, heroin use, sickle cell disease, and APOL1 risk variants. Biopsy shows exactly what the name says, focal segmental sclerosis. Unlike minimal change disease, FSGS carries a worse prognosis, and steroid resistance is pretty common. Then we have membranous nephropathy. This is also seen in adults, but it's specifically linked to PLA2R antibodies, hepatitis B and C, solid tumors, NSAIDs, and lupus. Because nephrotic syndrome causes you to lose antithrombin 3 in the urine, these patients become hypercoagulable. The highly tested major complication to watch for here is renal vein thrombosis. Rounding out the nephrotic branch is diabetic nephropathy. This presents with years of progressive albuminuria, often alongside diabetic retinopathy. Pathologically, the absolute hallmark is nodular glomerulosclerosis, the Kimmel-Steele-Wilson nodules. First-line treatment to slow progression is strict blood pressure and glucose control using an ACE inhibitor or an ARB. Section 3. Classic nephritic syndrome pathologies. The hematuria branch. When evaluating glomerulonephritis, serum complement levels are a huge clue. Low complement means heavy immune complex consumption. Think lupus, post-streptococcal GN, or endocarditis. Normal complement points you toward IgA nephropathy or posse-immune vasculitis. Let's compare two high-yield causes. Post-streptococcal GN follows a distinct latent period after pharyngitis or impetigo. Patients present with cola-colored urine, edema, hypertension, and low complement. Contrast that with IgA nephropathy, which triggers synpharyngitic gross hematuria within just days of a URI or GI infection, with totally normal complement levels. If you see palpable purpura, abdominal pain, and arthralgias added to the mix, you're dealing with IgA vasculitis. While the episodic gross hematuria of IgA nephropathy often resolves on its own, some patients progress to end-stage renal disease over time. Because of that, close monitoring of blood pressure and creatinine is the required next step. Section 4. Rapidly progressive glomerulonephritis, high acuity nephritic syndrome. RPGN involves a rapid loss of kidney function over a matter of days to weeks. The defining feature on biopsy is crescents in the glomeruli. If you see this nephritic picture paired with hemoptysis or diffuse alveolar hemorrhage, suspect Goodpasture syndrome. It's driven by anti-GBM antibodies, meaning the immediate next step is plasmapheresis. If the biopsy shows crescents but is posse-immune, meaning it lacks immunoglobulin deposits, you're looking at ANCA vasculitis like GPA, MPA, or EGPA. Clinical clues include sinus disease, pulmonary symptoms, neuropathy, purpura, and constitutional symptoms. Urgent treatment requires high-dose glucocorticoids combined with further immunosuppression. Section 5. Systemic glomerular diseases, lupus, and HIV overlap. Suspect lupus nephritis in an SLE patient presenting with proteinuria, hematuria, hypertension, active urine sediment, rising creatinine, low complement, and elevated anti-dsDNA. A kidney biopsy is mandatory here to classify the disease and guide treatment. Proliferative disease requires immunosuppressants like glucocorticoids plus mycophenolate or cyclophosphamide. For HIV-associated nephropathy, think of patients with advanced HIV, especially Black patients, experiencing rapid renal decline and heavy proteinuria. Imaging shows enlarged, echogenic kidneys, pointing directly to a collapsing FSGS pattern. The next step is prompt initiation of antiretroviral therapy and proteinuria management. Section 6. Next step diagnostic algorithm, the synthesis. Let's put it all together into a strict diagnostic workflow. First, quantify the proteinuria. Second, examine the urine sediment for RBCs or casts. Third, check the creatinine, complement levels, ANA, anti-dsDNA, ANCA, anti-GBM, and any relevant viral serologies. Finally, always perform a biopsy when the diagnosis is uncertain, if nephrotic syndrome isn't classic minimal change in the child, or if a glomerulonephritis needs specific classification. Let's apply this to a clinical challenge. An adult with a solid tumor, heavy proteinuria, and hyperlipidemia immediately flags membranous nephropathy. Sudden, severe flank pain points to renal vein thrombosis due to urinary loss of antithrombin 3. Mastering this framework lets you navigate any glomerular disease logically and keep the overarching rules straight. Nephrotic syndrome heavily raises infection and thrombosis risk, while nephritic disease raises the risk for severe hypertension and AKI.